We welcome you to the Javeriana University and to the second Congress of Patient Navigation in Latin America. For us, it's a pleasure to have you here on site, and also we send our special regards to those who are right now online via streaming. The objective of the Congress, 30 mejor. It's to talk about the patient perspective, patient navigation from a comprehensive view. So now we invite our board of directors, Dr. Peña Torres, Dr. Adib, who is joining from the online connection, Dr. Freeman, who is also online, and Dr. Nance Peña on the table to get us started with the presentation of the agenda. Now I will introduce the program that we will follow and we have prepared for you in this event. First, we will hear the national anthem of Colombia. Second, so now I request you to stand up for the national anthem of Colombia.
Muchas gracias. Pueden tomar asiento.
Thank you very much. You may be seated. For the event opening, we invite Dr. Esperanza Peña, the Dean of the Nursing School, Pontificia Universidad Javeriana.
Muchas gracias, Carmen Lucía. Buenos días para todos, de verdad.
Thank you very much and good morning. I am absolutely thrilled to be here in this event. I'm really happy. And in addition to that, it's an honor to open this Congress on a topic of such relevance. Strategy that has proven to have direct positive impact on the life of many people around the world. First, I want to highlight the story that gave birth to this innovating concept. Patient navigators came around in the 90s in the United States, in Harlem, New York. And the objective was overcome the barriers faced by patients, especially Afro-American women with a late breast cancer diagnosis. This objective to overcome the barriers is a concept that with time becomes stronger, not only in the United States, but in other countries. Many of them are members of the OECD and have achieved positive impact in different healthcare areas, from cancer to the healthcare of patients in high vulnerability, also in people who are not that vulnerable. We were talking with Nancy about that. Today, as it's evident in Latin America, in Colombia, Guatemala, today, specifically in Bogota, also this strategy has been well accepted for us at the Javeriana University, especially in the training of the master's degree of the oncological in alliance with the MPI. We have been working 3 years with the Lisma University in Guatemala. One of the first and most important fields of the patients navigators has been the cancer patients, as I was mentioning. Cancer. We know that making sure that patients get a timely, high quality healthcare is a condition that faces a lot of challenges. Amongst them, or one of them, are the access barriers, but also the coordination amongst the providers, and what is most likely to overcome the healthcare inequalities in many countries. A clear example of this program is the Patient Care Connect in the United States, implemented by the Alabama University, a program that uses patient navigators, not necessarily health clinicians or health professionals, but that are trained in supporting the patients through the entire journey, from the diagnosis to survival and even to the final stage of life. This model I'm talking about covers 12 oncological centers in several states and has proven how the introduction of Patients Navigator reduces the inequalities in access to healthcare, improves the quality of life of patients, especially in rural areas and urban marginal areas. Another field of patient navigators is a proven value in the care of transition. We know that patients who come from a hospital running to the home or from a healthcare to the social services face a series of difficulties that can require readmission or health complications. Navigator, especially so working with elder people with chronic diseases, play a really crucial and relevant role. In these cases, the navigators help in planning navigation during the discharge, coordinating the home visits, and offering call support so that the patient gets the required care, but that they can also navigate successfully the social and health systems. So this is proven to improve the quality and reduce the readmission of patients, which of course has an impact on the sustainability of the health system. Another challenge, a little more complex, is access of vulnerable patients to health care. People in conditions of high vulnerability, such as ethnic minorities, migrants, homeless people, or people who are not insured, usually face significant barriers in access to healthcare, which leads to late diagnosis and, in consequence, worse health outcomes. Patient navigators play a key role in being bridge amongst those vulnerable communities and the social and health systems, whether it's to the community dissemination, community visits, phone calls. Navigators help identify barriers faced by people, which can be even a language barrier up to financial barriers, and they provide them support so that they can access to healthcare and carry out the detection or rehabilitation tests or treatments. A clear example of this is the patient navigation program in Germany. There is the Stuttgart that works with the nurse students, and each model shows how navigators, especially those coming from the communities that they support, can make a significant difference in the life of the most needed patients. Without a doubt, an innovative strategy. I have made quite a few summaries of evidence around that, but I brought two success stories that have proven to have global expansion. Other countries in Europe have started to implement similar initiatives, but with different levels of execution. The lessons learned from this international experiences are priceless and provide us with the opportunity to adjust and improve our own models. That's where we are aiming with these strategies. The increase of chronic diseases and the growing complexity of healthcare to patients makes navigators to be more necessary today than ever. The health systems need to adapt to a world with patients need multidisciplinary care, social community care, and navigators are the link that allows for the integration of those services. It is key that as we move on, we focus on the sustainability of the patient navigation programs. The success of these initiatives does not only depend on the appropriate training of navigators, it also depends on the cooperation amongst all those engaged health professionals, clinicians, community organizations, decision makers, and of course, patients themselves. In this sense, organizations such as the American Cancer Society has been key in developing navigation models in order to approach the inequalities in access to healthcare. American Cancer Society has promoted the importance of the assessment of the existing models, looking for some more sustainable that offer the highest return on the investment, not only in financial terms, but also in terms of equality and access to health. To conclude, it's an honor for us in the Pontificia Javeriana University, having prepared together with MPI and the University of Guatemala such a significant event. I think that is a historic magnitude, which until today hadn't been carried out on site in Latin America. This Congress does not only represent significant progress in oncological patients' healthcare and service, but also highlights the commitment of the nursing school of the Javeriana University uh, with the training highly trained professionals able to lead the change in the field of oncological nursing. We have been the pioneers. In our institution, we work every day to strengthen our field as a key discipline in the comprehensive healthcare to patients, not only in Bogota, in all the country, but in territories such as Bogota with the complexity. We have committed to offer inclusive and quality education, making nurses that are change agents. I would like to highlight how important is our alliance with the Secretary of Health, a joint effort in order to carry out important social work so that we can guarantee that everybody can get the best care possible. On behalf of the nursing school, I really want to thank everybody for participating in this Congress which will be a landmark milestone. Let this be the beginning of a progress in the oncological healthcare where the social commitment are in the face of our work. Patient navigation represents one of the most promising innovations to healthcare, from cancer to the healthcare for people in conditions of vulnerability, managing transitions. However, in spite of all these efforts, we still need to keep assessing and perfecting the models to guarantee sustainability and its capacity of adaptation to the constant changes in the health system and the contingencies that are faced by our country today. Today, in this Congress, we have the opportunity to share experiences, learn from each other, and build the future of patient navigation. I am sure this will be a productive space full of valuable ideas so that we can keep making progress in this field. Thank you very much. Welcome.
Muchas gracias, Esperanza. Invitamos al doctor
Thank you very much, Esperanza. Now we invite to Dr. Adib Rodríguez, the Dean of the Health Sciences faculty. He will be joining us online. Go ahead, Dr. Rodríguez.
Buenos días.
Good morning. Yes, we can hear you. Good morning. Dear Dean of the Nursing School, Pontificia Javeriana University, Masters Esperanza Peña Torres, Director and Founder of NPI, all the attendees to this Congress, good morning. It's an honor for me to talk to you, especially for those that day after day assume with commitment, but especially with a lot of honesty the task of taking care of people who are facing diagnoses such as cancer and other chronic diseases. The purpose of this reflection is to share an academic and regional view on the patient appreciation or evaluation model, as mentioned by Esperanza, that has proven to improve the continuity of quality, the patient experience, and the results in health. In our Latin American region, this focus has been adapted to the social and economical activities, becoming a strategic and human tool to strengthen the health systems. According to the American Cancer Society and the National Cancer Institute, patient navigation is defined as an individualized process, guide process for guidelines, education, and support that helps the people to overcome barriers in the health system, from diagnosis to the final resolution of a treatment. In practice, the professional navigator that frequently is a nurse or social worker with specific training acts as a coordinator of care, facilitator of interdisciplinary communication, and patient advocate, making sure that the clinical decisions can be translated into effective and timely decisions. Diverse international studies have proven that the navigation programs reduce the diagnosis and treatment times, especially in breast cancer, colon increased adherence, and the follow-up of patients in extended treatment, improve the patient satisfaction and the perceived quality of care, strengthens the communication amongst the level of care, and reduce the system fragmentation. In Latin America, although the scientific evidence has been proven with evidence in Argentina, Mexico, Colombia, and Chile that report similar benefits, adapting the model to the local resources and the needs of the population. Colombia, for example, the breast cancer navigation programs have significantly reduced the loss of follow-up between the diagnostic and the onset of a treatment. In Brazil, it has been considered in the health policies as part of the strengthening of the oncological network. Nurses play a key role in the implementation and sustainability of the navigation programs. From the approach of comprehensive care, it allows for the integration of clinical, social, educational, community experiences or approaches in the patient experience. Some of the key competences that the literature highlights for the navigator is the therapeutic communication and counseling abilities, case coordinator, interinstitutional coordination, patient and family education for the informed decision making, evaluation of better access, and design of a personalized care. In this form, in the group of nurses, we consolidate a strategic approach for the access to healthcare services. However, the implementation of these navigation programs in our region faces important challenges. Structural limitations or limitations of the health systems guaranteed by the fragmentation of services and the inequality in the distribution of services. Lack of formal recognition of the role of the navigator, both in the regulatory framework and in the healthcare systems, in the training in skills of navigation, communication, coordination of care, scarce local communication that documents and assesses results with rigorous methodologies. Nevertheless, these challenges need to be seen as opportunities. Academic institutions, hospitals, professional institutions are in the position to lead research process of education and regional cooperation, so that we can consolidate models that are proper, that are cultural, pertinent, and as mentioned, sustainable. One of the main strengths of Latin America is the capacity to learn and to adapt. That's why it's key to document and share our experiences, as we will be talking in this Congress. building the repositories, networks, and spaces for academic exchange that make visible the local initiatives and encourage collaborative research. Congresses, seminars, scientific communication need to work as a platform to share the lessons learned and the impact results. Only like that we can strengthen Latin American network of patient navigation that is supported by evidence, the ethics of care, and the social commitment. Patients navigation represents an evolution to the paradigm of care, a disease-centered model, now moving to one centered on the person and its journey on the health system. And I insist, focus people-centered. In contexts where oncological and chronic diseases represent a growing challenge for the sustainability of the systems, integration of the systems and navigation programs led by the nursing services need to be a priority and need that cannot be postponed. I invite each and every one of you, future and current health professionals, to educate yourself, get trained, and share your experiences because shared knowledge is the path for the transformation. When a clinician supports with the patients and compassion, when a nurse guides with knowledge, with humanity, the health system becomes more fair, more efficient, and much more humane. Thank you very much. I wish you the best in this Congress, and thank you very much for the invitation to participate. Thank you very much, Dr. Rodríguez.
Bueno, nos acompaña nada más
Good.
y nada menos que el
And
doctor
here we are with Dr. Harold Freeman, father and pioneer of the patient navigation model. He is online from the United States right now. So we're going to start with a video that he has recorded for us. And after that, so that we don't stop or cut off the communication here, we will hear Bachelor Nancy Peña, who is the Director of Patient Navigation International, NPI. Dr. Freeman, welcome to this great meeting.
Good morning. I'm Dr. Harold Freeman. I'm very happy to be with you today at the second Patient Navigation Congress in Latin America. And I have prepared a talk today to tell you how navigation developed in the community of Harlem and how it extended to the whole country and ultimately to the world. The challenge of navigating people through a complex healthcare system. And this is what I'm going to talk to you today about. The way I see it is through this patient navigation model that you see in front of you. Surely on the outreach side, we have to reach out to help to tell people to come into the system for a particular test. That is called outreach. The problem is when people come in who have an abnormal finding, what can we do to help them to get through the complex system to diagnose and treatment? And so the early concept of patient navigation started at the point of an abnormal finding, such as a lump in the breast. A poor person coming to the Harlem emergency room with a lump in the breast, who had to wait a long time to see a doctor first, and then was told that they did not have insurance and they had to go to find coverage before they came back to the hospital. So the patient navigation model was really based on the challenges that people who were poor in Harlem had to meet to get through a system, the elimination of the barriers to get them to resolution. And that was the patient navigation model in its beginning back in 1990. So with that beginning, the question is, so what is the current system in America that's called patient navigation? Well, it's come a very long ways. From 1990 to now, the current situation is that patient navigation is a part of the healthcare system in America. And how did that happen? It happened because we were able to show the Congress of America, for example, that this was what had to be done to save lives. So by the year 2005, the President of the United States, who was George Bush, signed what was called the Patient Navigation Act based on what had happened in Harlem. And the Patient Navigation Act gave funding to assist people through the journey through the healthcare system. And the current situation in America is that patient navigation is now covered under Medicare, which is the system of payment for healthcare for people, particularly who don't have money. That is the current system. So how do we get from early Harlem to the current system? How do we connect community to patient navigation for the whole healthcare system? The challenge was great. We found out that navigation has to include people who are not professional, and we call them patient navigators, along with people who are professionals, such as nurses and social workers, on one team. That's not natural in the healthcare system in America, nor is it natural anywhere else. So one of the critical things to do to develop patient navigation is to create a team of people that involve people who are non-professional, working closely together with people who are professional, like patient navigators working with nurses and social workers, concentrating on connecting the patient's journey to the point of resolution. So that's what's happened in America. And the question is, how could Latin America and other parts of the world, Asia, implement the patient navigation system? I think that the policymakers have to understand the real challenges that patients face in determining what the policies should be. Now, for an example, if a patient is uninsured, in America, the coverage is called Medicaid and Medicare for poor people. If a patient is uninsured, they don't have a way to get into the system at all. So policymakers have to create policies so that people have healthcare insurance or a way to get into the system at all. Policymakers have to understand that people that work in communities that are called patient navigators in communities don't have an easy way to work within the hospital system itself. So in Harlem, what we did was to create a system in which the community patient navigators were also brought into the healthcare system itself. This is unusual in healthcare, to bring people from the community who understand the problems of patients into the system itself. And the critical thing in Harlem that helped us to make navigation possible was the acceptance of the patient, of the patient navigator who had a community origin to work within the hospital system itself. And so, to me, one of the barriers that has to be solved by policymakers is to create a system where the patient navigator from the community is within the system. the issue is that community patient navigators stop at the door of the hospital. They need to be welcomed into the hospital and work along as one team with the nurses and the social workers and the doctors. So that's a policy issue. And the big change that took place in Harlem was when patient navigators were brought into the hospital itself. And I'll give an example. I had a breast clinic. I was in charge of it in Harlem. And I brought patient navigators who worked in the community to be in the room with me when I examined the patient and told the patient, you need to have a biopsy of the breast, an uninsured patient. The navigator who was witnessing my examination then would take the patient to another room and sit down with them, the patient navigator, sitting down with the patient and asking the key questions to the patient. Did you understand what the doctor said? Many times the patient did not understand. No, number two question, do you have health insurance? The answer may be no. Then the navigator has to find a way to get them covered so they can have the service at all. What other problems do you have? The patient would say, I'm afraid, I fear the hospital system. I don't trust the doctors. The navigator has to find a way to create trust in the patient. So this connection of the patient navigator, which had not been in connection with the hospital before, becomes a part of the hospital team working very closely with the doctor and the nurse and the social workers, but directly with the patient. This is the critical issue of how patient navigation became successful. And when we showed that we increased the 5-year survival of breast cancer in Harlem from 39% to 70% using two things, patient navigation combined with free screening for breast cancer, this created saving of many, many lives. So the policymakers need to be shown the way to create the policy. And so finally, I was able to argue to the Congress of the United States in person to say what had happened in Harlem. And this was embraced by the Congress of the United States so that the Patient Navigation Act was passed in 2005 by the United States Congress with no negative votes. This was a sensational change. This was what happened in America, and this is the type of thing that can happen elsewhere. And so the bottom line is to understand the value of doctors and nurses who are skilled, first of all, to understand that. But to also understand that ordinary people who are in communities don't necessarily have a way of getting into the healthcare system to have the treatment given. I come into Harlem as a surgeon, knowing how to cut cancer out of Harlem and thinking that I can do that. I can't do it because of the problems that I face. So the issue for the policymaker is to understand the journey that the patient must take to get from where they live through a complex system and eliminating the barriers to movement, which are financial barriers, communication barriers, barriers of fear and distrust. And that is what I say to the policymakers. And the answer is a team of people. And I'd like to give an example again, as pictured here, and the mile relay example. I'll say it again. Picture a mile relay race. There are 4 runners, that are carrying a baton. The baton is the patient, as you see in the diagram. It's one team. The four runners, the first runner runs as fast as he or she can and passes the baton, the patient, to the next runner. And then it goes on to the end of the race. And for the patient, the race isn't over until the fourth runner or navigator crosses the finish line. And that is what navigation is all about. Teamwork involving patient navigators, doctors, nurses, and social workers working on one team to assure the rapid movement of a patient to resolution. And that is the best example I can give to show policymakers what patient navigation really is. In order to have a successful patient navigation team, all the navigators have to be trained to be navigators. The non-clinical navigators have to be trained to understand the problems that the patient has in the community, such as lack of insurance. What do I do about that? How do I get a patient who is uninsured to have insurance coverage? In America, that's through Medicaid and Medicare. The patient navigator, who is the non-clinical, has to have the capacity and the sensitivity to speak to and learn what the problems are that are faced by the patient. For example, if there's a transportation issue, the navigator has to solve that. If there's an issue of fear and distrust, the navigation has to get the confidence of the patient not to be afraid of the hospital, to know the hospital is there, the people in the hospital are there to help them. Those are examples. So the barriers that patient faces have to be understood by the patient navigator, and that takes training. And the navigator has to be trained to understand the hospital system itself and connect to the people within the hospital, such as the nurses and the social workers. So the training of the navigator becomes a critical issue to solve the navigation problem. And thank you very much for the honor of speaking to have a chance to talk to you at the second Patient Navigation Congress in Latin America. I believe the solution to many of healthcare problems is to navigate people through the system, and essential within the navigation solution are regular people who are the patient navigators. And I'm honored to be able to talk to you today. Thank you very much.
Buenos días a todos.
Good morning to everyone. Good afternoon, good night, wherever you may be tuning with us. My name is Nancy Peña. I am founder and director of NPI. I am honored to be here. I would like to ask if Dr. Freeman is online.
Good morning, Dr. Freeman. This is Nancy. Can you hear me? Okay. Entonces, mientras se comunica el doctor, voy a darles
Meanwhile, I'd like to welcome you. To start, it's an honor to be here in Bogota in the second Patient Navigation Congress of Latin America 2025. I'd like to start saying hello to the health authority and the academia, our colleagues of Javeriana University, to the ISMO University, and also the collaboration that is always special with George Washington Cancer Center, and all the institutions that have backed us up, and especially our sponsors. I also say hello enthusiastically to those online from Latin American countries and also places such as Romania, Philippines, Brazil, and the United States of America, among others. Your presence confirms that patient navigation is a global movement already, deeply rooted in our region. We unite in this historic moment, as Dr. Peña said. Just a few years back, speaking about patient navigation seemed an innovative concept that was kept only for high-income countries with robust health systems and big budgets. Today, thanks to scientific evidence and practical experience, we know that navigation is not a luxury, but a key tool to guarantee access, continuity, and dignity in health care attention. And what's most relevant, it's not limited only to oncology. Navigation is having a deep impact in areas such as diabetes, heart diseases, HIV, health, and other chronic conditions that represent grave challenges for us. In Latin America, the reality is complex. Fragmented systems, geography distances that separate patients from the attention and services, economical and cultural and language barriers, and deep social inequalities. Patient navigation raised as a bridge that links patient with the system and the system with communities, and communities with the hope of a better access to health. This Congress is proof that our region is moving forward. Each country here represented brings stories, learnings, and models that enrich how we build more humane systems that adapt to our needs and that are more sustainable. From NPI, we have assumed this commitment of this transformation alongside proudly with Pontificia Universidad Javeriana and ISMO and George Washington Cancer Center. Thanks to this joint effort, hundreds of professionals and volunteers have been trained, and other hundreds of navigators that we have here and that are online have trained themselves and certified themselves through NPI with the endorsement of the institutions I already mentioned. And what's more important, every certificate represents the support of a dozen patients that have been accompanied, families that have been orientated, and a community with better access to health. This is not only an academic achievement, it's a guarantee for patients that navigators are ready with high international standards, but also with cultural and language pertinence. An example, an indigenous female in Guatemala, thanks to a navigator, could have an early breast cancer diagnosis and access the opportune treatment despite being 13 hours away from the hospital. In Colombia, an elderly old man that found through his navigator someone who clearly explained his option, accompanying him and his family in every single decision. In the United States, a migrant family that received information in their own language, breaking this barrier and this fearful barrier, giving them information and giving them vital access. This reminds us that patient navigation is not just a concept, but we transform lives. What we celebrate today is not only a Congress, but we are consolidating a network that crosses borders, shares knowledges, and responds to common needs, which is making our health systems more humane. Navigation is now an emerging right in our region. It's the language of equity and empathy applied to health. This encounter sums us to think about the future, as Dr. Freeman was saying and Dr. Peña were saying, and also Dr. Rodríguez, to look deep into the future, how we consider shared standards for the region, how we integrate navigation in public policy making sustainably. How will we manage that every hospital and every community has a well-prepared navigator? Besides, we'd like to deeply thank every single institution that have supported us in the academia, NGOs, foundations, organizations, and sponsors, and also a very special thank you to all those who have trusted us in NPI and the Pontificia Universidad Javeriana as the other allied partners to strengthen capacities. And we want, most of all, to acknowledge each one of you navigators, your task, your daily work that may not be so visible, but that it's the essence of this movement. You are the ones that transform information into results and theories into concrete practice. May this second Congress of Patient Navigation in Latin America be a knowledge space, collaborative space, and inspirational space. May we reach agreements and alliances that may allow us to keep growing. Welcome to Bogota. Welcome to this Congress. Welcome to a future where patient navigation will cease to be an alternative to become an obligation, an ethical obligation, a right patients have, and a strategy of public health. Thank you very much.
Okay. So vamos a ver si el doctor
Okay, so we will see if the doctor can give us a few words to start this Congress. Let's see if we can hear Doctor online.
Can you hear me?
Yes, we can hear you, doctor. How are you doing today?
Yes.
Okay, doctor, so we are so honored to have you here live. We already listened to you, watched your video. And doctor, do you mind to open your camera, please, so we can see you here in the auditorium?
Let's see. Let's see.
Yes, I think in the bottom of the screen, you will see the camera near to the Microsoft icon. So we just need to push there if possible, but if not, it's okay, doctor, thank you.
I'm unable to bring up the picture. I can hear you.
It's okay, doctor, so it's okay, don't worry about it. So, well, first of all, we want to thank you for taking the time to talk to all our audience. And we are so excited and honored to have you here. And we just have one question for you, doctor, since we talked before about how challenges in Latin America to involve Minister of Health to finally, engage patient navigation. Like you just mentioned, right? In the United States, the Congress passed the law for navigation. So the question we have for you is, what do you recommend for Latin America? Then we have more challenges than the United States to engage Minister of Health to pass laws of navigation.
Well, I've given a lot of thought to this over the years. And the best way I can answer this is to tell you what happened in Harlem, finally to get to the point where the government is paying patient navigators to do their work. This began with documenting that Harlem itself was an area of excess cancer mortality. There are ways to do that. They recorded statistics by the government itself to show what geographic areas and what areas patients are dying at a high rate. Now, they found then that Harlem, New York, had the highest cancer death rate of any other place in the state of New York at that time. So that's the first step. And then we documented who lived in Harlem, what were the characteristics of the people living in Harlem. For example, what was their income? What was their level of education? What was their culture? What was their ethnicity? How many were uninsured as a second point? So now you know an area of excess mortality in which people of a certain type, uninsured people, poor people, live. And then the next step is to create a patient navigation teaching program, which I know you know a lot about as a teacher yourself. So we have to find a way to teach the people who are living in Harlem as citizens to be patient navigators, as I previously had described in the talk that we heard. So there has to be some organization of people who understand navigation to teach the people to be patient navigators. Now, when you bring the strength of the people in a community to help the people in their community, you have a huge strength. It's much stronger than government giving instructions to people. So now you have a teaching program, and you're teaching patient navigators to do their work. And after you do that, you begin to request funding for the work that you've done. Now, the early funding in Harlem came from the American Cancer Society, and later from the Ralph Lauren Center and other donors. And finally, just less than a year ago, the laws of America were changed. In other words, the Medicaid and Medicare laws were changed so that patient navigators are paid for their work. So it came a long way from a community where people were dying at a high rate, find out who they were, what were the circumstances, teaching them to be navigators themselves and joining them into a team within the hospital, including the nurses and the social workers and the doctors, without making them a part of the system. And finally, explaining to the Congress or the Secretary of Health or whomever is in charge where you are, the value of this. And that is what I think should be done in all the countries in South America that are involved and elsewhere. In other words, it's not an easy job. It takes a lot of effort. It takes understanding.
Yes.
No more powerful force in America and elsewhere than people helping other people. And I was amazed to find that people love to help people. And so navigation could be a guiding force, even to show us how to be cooperative in other ways beyond medicine. So in summary, patient navigators are people from the community who work on a team with people within the hospital. And the goal is to teach people how to navigate a complex system across the healthcare continuum, which I will describe to you what I believe it is.
Okay.
People live in the community, so you have to go to people where they live.
Yeah. Thank you. Yeah.
People need to get into a facility for a diagnosis and treatment. You have to guide them through to the point of resolution. And finally, they're still alive and they still need support them through survivorship to the end of life. And that is what patient navigation is.
Okay. Well, thank you, Dr. Freeman. And yes, I know that, as you mentioned, right, it's not like an easy process, but since we have you as a mentor and also, we have so many literature, I think this is a great, tips for Latin America and for other countries to start thinking about how the process should be to achieve our goal. And we appreciate, again, your time. And since, just to wrap it up, again, thank you so much for everything. Thanks to you, we are here together today, Dr. Freeman. Thanks, this is your legacy. And we just being very honored to have you opening this second Patient Navigation Congress in Latin America. So thank you so much, and bienvenidos todos de nuevo, y con eso aperturamos el Congreso. Gracias.
Welcome, everyone. And in this fashion, we start our Congress.
Les agradecemos personas que
We
nos
thank
acompañaron en la
all
mesa de
those
instalación
that
del
were
Congreso
in the
que
installation
invitamos
table
a tomar
of the Congress
asiento.
to be seated, please.
Nuevamente,
Have a seat.
la Facultad de
And once
Enfermería
again,
Pontificia
the nurse
Universidad
faculty
Javeriana
of
y la de
Pontificia
Paciente
Universidad
Pacientes
Javeriana
Internacional les dan
NPI
la bienvenida y les
welcomes
agradecen su
everyone
presencia
and thank
tanto
your
remota e in
remote
situ
and
en el segundo Congreso
in-person
de
presence in
Navegación de
this
Pacientes
second
en Latinoamérica.
Patient Navigation
Queremos
Congress
darle
of
un
Latin America.
saludo
We'd
muy
like
especial a
to
las personas
give
que
a
nos
warm
acompañan
hello to all
en el
those with
auditorio
us
y que
here
vienen de otros
in person
países
that
como
comes
México,
from other
Costa
countries
Rica, Brasil,
such
Chile
as
y
Mexico,
también
Costa
a quienes
Rica,
están
Chile, and all
conectados
those that
desde
are
otras
logged
latitudes.
in online from other
Tenemos
latitudes.
personas
We
conectadas
have
desde
people
Estados
online
Unidos,
from the United
Canadá,
States, Canada,
Chile, también Costa
Chile,
Rica, México,
Costa Rica,
Guatemala,
Mexico,
Honduras,
Guatemala,
Ecuador,
Honduras,
Nicaragua,
Ecuador,
entre otros
Nicaragua,
países.
amongst
No quiero
others.
dejar a
I
nadie
would
por fuera. De
want to
verdad, les
forget
enviamos un
anybody.
saludo
We
súper
send
especial.
every single
Y
one
en
of
este
you a
momento
warm
vamos,
hello.
como lo mencionó
And as Nancy
inicio a
mentioned,
nuestra
we
agenda
formally start
oficial.
our official agenda.
En este momento vamos
In this
a
moment,
iniciar con el
we
primer
are to
conversatorio.
start with the
Nos
first
acompaña
panel.
la licenciada Rachel
We
Allende,
have
quien
Rachel
nos dará
Allende,
el
who
conversatorio
will
titulado
be the
Experiencia en
moderator of
navegación de pacientes en
Experience
Estados
in
Unidos
Patient Navigation in the
y
United
factores
States
para una
panel and
implementación
factors
exitosa
for
de
a successful
navegación de
implementation
pacientes.
of patient navigations.
Nos acompañan de manera
We
presencial la
have in
doctora Mandi
person
Pratt-Chapman.
Dr. Mandi Pratt-Chapman.
Vamos antes,
Before,
bienvenida, doctor.
welcome,
Toma
doctor,
asiento.
please have a
Voy a
seat.
hacer la presentación
I
de las
will
personas que van a
present
estar en el conversatorio.
everyone
La doctora
present
Mandi
in this.
Pratt-Chapman
Mandi
es
Pratt,
directora del
this panel,
programa de
she's
navegación de
director of the
pacientes del
program of
George
patient navigation of the
Washington
George
Cancer Center,
Washington
quien nos
Cancer Center.
acompaña de
She
manera
is
presencial y le
here with us
agradecemos estar en
in
Colombia.
person. We thank her for
Y
being
la
here in Colombia.
licenciada Jenna
Gina
gerente
de
del
San
programa de
Jorre,
apoyo global de
manager
pacientes de la
of
Sociedad
global patient
Americana de
support of
Cáncer de Estados Unidos, que
American
va a estar de
Cancer
manera
Society. She will
Vamos
be
a ver los
remotely
invitamos a ver el video
joining the panel.
y
We invite you
continuamos
to see the
con
video
el
and
conversatorio.
we will resume with our panel.
Porque nadie debería enfrentar el
Because
sistema de
nobody
salud
should
solo,
face a
nació una
health system
misión
by
que hoy cruza
themselves.
fronteras.
A mission was
Navegación de
born at
Pacientes
cross-border.
Internacional,
NPI
capacita y conecta a quienes acompañan con empatía y
trains
compromiso.
those that
Desde
work through
2017
empathy and
hemos
commitment
formado
ever
más de
since the year
150
2017.
navegadores de
We have
pacientes
formed
en
more
11
than
países de
150
América Latina.
navigators in
Más
11
de
countries of
300
Latin America. More
pacientes
than
han
300
sido
patients
acompañados durante su
have been accompanied
tratamiento,
through their
porque
treatments
navegar
because
es transformar.
navigating is
Nuestros estudiantes
transforming.
lo dicen
Our
mejor que
students
nadie.
say it best than
Mi
anyone.
experiencia
My
fue
experience
única,
was unique.
única, siempre lo voy a decir
I
porque
was,
me
I
ayudó
have
a
to say this
empoderarme yo
because
primero
I empowered myself,
y en realidad
and
para
in
poder
reality,
enseñar y empoderar al
I could
paciente más que nada,
empower and
¿sí?
teach what
Cambió
I
en mi
to the
forma de
patients. It
trabajar.
changed me in the way I
La
worked.
relación con ellos
The
siempre es la
relationship
misma.
with the
Hay
patients
pacientes de muchos años
is
que
not
ya no
always
son seguidas,
the same.
pero siguen
Patients
teniendo el
change and
teléfono,
relations
entonces por
change,
otras
and
circunstancias por
so
ahí
for other
siguen mandando
circumstances,
mensaje. O sea, la
the
relación
message needs to
siempre
change.
sigue
So
estando.
the
La
relationship
experiencia fue muy
changes, but will always
gratificante,
be there. It's
realmente,
highly gratifying
pues por mucho tiempo estaba
that
buscando como esa
for a long
posibilidad de
time I was
certificarme
working
en
that
navegación.
possibility
En el
to
país,
certify
pues
myself
me
in patient
surgió esa
navigation.
opción
And
con la
so
información
in
que
the
se me
country this is
brindó
starting, and with the information that I was
en la
giving
certificación como navegador,
about the
pues
certification,
pude
I
aprovechar varios de esos
could
conocimientos
make
para
the
poder
best of the
implementar
knowledge to
en mi área de
complement
trabajo.
myself in
Entonces me
this
parece que es
work
muy
field. And
positivo
so I
ese
think
aprendizaje que se logró
that
tener.
these
Actualmente
learnings
yo
are
soy jefe de
very
la
valuable.
navegación, yo soy
I
el líder de un
am
equipo de
the
navegadores en una
leading
clínica
of a
privada acá en
navigators team
Cali, en
in
Colombia.
an
Y los
institution in
pacientes
Cali,
lo
Colombia.
confirman. Un
Patients
navegador
confirm it.
hace la
A
diferencia.
navigator can make the
Mi
difference.
nombre es Gloria Monroy
My
y
name is
tengo
Lore Monroy.
47
I
años.
am
Fui diagnosticada
47
en
years
mayo
old.
del año pasado con cáncer de mama.
I've
El recurso
had
más
breast
importante que los
cancer,
navegadores
and
me dieron fue que
what
inmediatamente
I
me
learned
vinieron
through
y me
patient
llevaron con el
navigation,
doctor Chacón, que es especialista en senos. Me han apoyado ahí en el
I
hospital
worked
diciendo
with
que dónde
six
está la
specialists.
clínica con la doctora, dónde está el laboratorio, dónde
They
está
guided me
la
to
sala de
where the labs
quimioterapia y he
were
platicado con
and
gente
where
aquí en el
everything
hospital San
was.
Juan de Dios
And
que
here
ellos
in
no
the
tienen
hospital San Juan de
navegadores y
Dios,
les ha costado más el
it's
proceso.
been a
Y yo que gracias a Dios estoy
very
con ellos
valuable work.
y
They've guided
me han
me.
facilitado el
They're always with
acceso y
me.
ellos me han
They've
ayudado
granted me
bastante.
access
Hemos
to the
crecido junto
services.
a
We've
universidades,
grown up
hospitales
thanks to universities, hospitals, and allied organizations, we create a new online module, we've
revisamos competencias
been part of
globales desde
international
países
conference.
como Filipinas
We've
y
performed
formamos parte del
international
nuevo
events
curso de
with countries
navegación
such
en
as Venezuela, and
español
we make part of the
George
new course
Washington
of
Cancer Center.
patient navigation
En
of the George Washington
2023,
Cancer Center. In
celebramos nuestro
2023, we
primer
celebrated
congreso en
our
línea.
first
En
online
2025,
congress. In
el encuentro será en
2025,
Colombia.
the
Queda el
meeting
segundo
will be
congreso
in
de navegación
Colombia,
de
the
pacientes de
second patient
Latinoamérica
navigation of
2025,
LATAM region
en
in
alianza con la Pontificia
Colombia
Universidad
in the year
Javeriana. Un
2025
espacio para
with
compartir
the University
experiencias,
Javeriana, a
fortalecer
space
la
to share
formación
knowledge,
y unir
strengthen
esfuerzos.
formation, and
¿Eres parte
join
del cambio?
our efforts. Are
Únete
you
al
a part of the
movimiento.
change? Join our
Inscríbete,
movement.
participa, capacítate,
Participate,
navega con
learn,
propósito.
train
Te damos
yourself,
la bienvenida
navigate
al
with
segundo
purpose.
Congreso de
We
Navegación
welcome
de
you to the
Pacientes de
second Congress of
Latinoamérica
Patient Navigation
2025.
in Latin America 2025.
Bueno, invitamos a la
Okay, we
licenciada
invite Jenna de San Jorge, manager of a global program of the American Cancer Society of the United States. Doctor, please, can you please share your camera and you may start.
Hi, everyone. One moment, please. I thought, can you see my slides? Can everyone see my slides?
Sí, sí las vemos y le pedimos por favor que cuando
Okay.
Yes,
pasamos
we
la
can see
siguiente
them.
nos diga
And
Okay,
I
perfect.
beg you
I
to
thought I
please
shared.
direct us
Okay.
when you need us to pass
So
slides.
good morning, afternoon, and evening, everyone. It's a pleasure to be here today. Buen día a todos. I'm really excited to be presenting at this year's second MPI Congress, and I'm sorry I can't be there in person, but I am happy to join the online community. For those who don't know me, my name is Jenna de St. Jorre, and I am a program manager for global patient support at the American Cancer Society. I'm based in Washington, D.C. So today I'll be presenting on our ACS Beacon Initiative, which is for global patient navigation programs. And I'll briefly highlight other ACS global initiatives that connect to patient navigation. Next slide, please. So our vision at ACS is to end cancer as we know it for everyone. And we do this through a three-pronged approach to improving the lives of cancer patients and families. And we do it through advocacy, research, and patient support. So as we know, cancer can affect anyone, but it doesn't affect everyone equally. So there are many barriers that can impact a person's ability to prevent and then detect, treat, and survive cancer. And these barriers are because of those deeply rooted, longstanding inequities that happen at all levels of society. And they do tend to require an intentional effort for equal cancer outcomes to happen. Next slide, please. While most of the work at ACS is focused on helping people living with cancer in the US, ACS also has a global mission. So we support individuals and organizations around the world to increase access to cancer prevention, care, and treatment to improve health outcomes and end cancer disparities. So we work in prevention and screening, patient support, and healthcare provider support. And our current work spans 80 countries. So today I'm presenting on behalf of the Global Patient Support Team. Our work is primarily focused on improving patient experience. We promote patient-centered care and driving its delivery through two key areas, patient navigation and then patient and caregiver education. So our team also ensures the delivery of patient-centered care through our organizational strengthening work to building up civil society organizations. And they play a vital role in ensuring the patient voice and patient experience are at the heart of care delivery. Next slide, please. So here's our global patient support team. And I just want to mention Andrei Shibisov will be presenting later today on patient navigation implementation strategies. And he'll be doing this alongside Dr. Yomna Sharif, who'll be sharing the experience of the Bahia patient navigation program in Giza, Egypt. So look out for their presentation. I believe it's in 2 hours. Next slide, please. So at ACS, we're on a mission to promote and facilitate patient navigation adoption and adoption around the world through 3 key efforts. We have the Beacon Initiative, which supports health institutions and cancer organizations in low and middle income countries to design and implement and then sustain cancer patient navigation programs. We then have the Spark Initiative, which builds on Beacon, and it supports this integration and expansion of patient navigation into national cancer care delivery systems. And we're currently doing this in 3 countries, in Indonesia, Kenya, and Nigeria. And then we have the Global Alliance for Cancer Patient Navigation, and this aims to convene global partners to identify, elevate and unify solutions for those common challenges to patient navigation, particularly around adoption, implementation, scalability, and the sustainability. Next slide. So the Beacon Initiative stands for Building Expertise, Advocacy, and Capacity for Oncology Navigation. It supports health institutions and cancer organizations in low and middle income countries around the world with a focus on addressing health disparities in cancer care. So it helps health institutions and cancer organizations design their cancer patient programs as well as implement them and then sustain them. And it supports this integration of patient navigation into that cancer control planning and the cancer care delivery. So Beacon is free to access and use the resources. We do have an application process. The online platform includes the Global Oncology Navigation Toolkit, which is a comprehensive resource, and it features hundreds of online learning modules and downloadable materials to support program development. We also have the Global Oncology Navigation Community of Practice, and this is a network for navigation practitioners who are members of Beacon to connect, share their experiences, and learn through virtual events and other collaborative opportunities. Next slide, please. So our journey in developing and implementing Beacon started 10 years ago. From 2015 to 2020, we supported studies in Kenya and Uganda, and these were to assess the needs of cancer patients to inform the development of patient navigation programs at 2 national referral hospitals. That was the Kenyatta National Hospital in Kenya, and then the Uganda Cancer Institute in Uganda. So our work in Kenya and Uganda has allowed us to test these different capacity development approaches and resources before we actually started using them at a wider audience. So in 2020 to 2021, we convened an advisory committee of global practitioners and experts in patient navigation to inform that design of the Beacon Toolkit. This including Nancy Peña, who's currently on the stage, as well as other early patient navigation implementers from around the world. So based on their recommendations, the development of the toolkit focused on the what and the how for patient navigation programming. And the how is really essential because it's not usually included in other patient navigation toolkits and resources. So that was a real focus for the toolkit. So from 2022 to 2023, we launched and evaluated a 15-month pilot of the newly developed Beacon Initiative. And we did this with 10 health institutions and cancer organizations from 8 countries. And the pilot included 1 health institution in Guatemala, whom Nancy also connected us with, and then 2 cancer organizations in Brazil, all who are still part of Beacon. And today I do want to recognize our Beacon member from Guatemala, the Hospital General San Juan de Dios, because they recently launched their patient navigation program on September. So please join me in congratulating the hospital, including Doctora Patricia Chacon and her colleagues, because I know she's currently in the auditorium. So felicidades, congratulations to you all. And then in 2023, we opened Beacon to the broader global community of patient navigation practitioners. And this community continues to grow as we add new features and we continue to network around patient navigation. So this year we launched the SPARK initiative, and that stands for Supporting Patient Navigation Adoption, Replication, and Knowledge Exchange. So SPARK seeks to create an enabling environment for patient navigation by leveraging our Beacon resources so we can spark that patient navigation policy and practice changes, and particularly in a country. So there are 2 ways SPARK does this. We do it by assisting national leaders to identify policy gaps and opportunities and advocate for those policy changes to then integrate patient navigation into that cancer care delivery system. And then also by supporting health institutions and cancer organizations to design and implement those effective, sustainable, and coordinated patient navigation programs. And those are based on those countries' cancer care structure, the needs of their populations, and the resources available. So SPARK implementation is from 2025 to 2030. It's currently in Indonesia, Kenya, and Nigeria. As I mentioned, it's a country focus. We hope, however, in the future to use our learnings from leading this process in the 3 countries to support other countries to integrate patient navigation into their national cancer care system. So watch this space. Next slide, please. Okay, so the heart of Beacon is the Global Oncology Navigation Toolkit. It provides a range of training and technical assistance resources on navigation program design, the implementation, and then the sustainability or integration of these programs. So the toolkit prepares users to cultivate a team approach to design and implement patient navigation programs, to measure those outcomes and share progress, to anticipate any change and manage it, as well as to plan for sustainability. So in the toolkit itself, you'll find that we pose these key questions in consideration. We showcase user examples. The toolkit itself is self-guided and it's self-paced, and it provides this easy to adapt resources and practical guides. So the graphic on the left of this slide shows the 3 different phases of the toolkit, from laying the foundation from your program to designing and launching your program to implementing and strengthening it. So there are 3 sections within each phase, which go into depth to prepare health institutions and cancer organizations with relevant resources. So phase 1 introduces the fundamentals of patient navigation, and it supports users to identify how to address barriers to timely and quality cancer care. And it starts with this section 1, which is more theoretical and lays out the foundations of why patient navigation is important, particularly in eliminating access to treatment barriers and improving health equity. This phase also includes guidance and resources on conducting a needs assessment in your patient population and then creating a vision for your program. So phase 2 provides tools for designing the program. It's determining those staff needs, drafting SOPs, hiring and retaining staff, etc. And then phase 3 is about using data to learn from your program and adapt that data to changing patient needs and implementation environment. So it does support you in resource mobilization efforts to then sustain your program, and in supporting your team by using soft skills, to successfully manage people. So each section is broken into several activities with resources to download online and which you can also work through offline. Next slide, please. So the toolkit lives inside this online community platform, and here's where we can connect our members to one another. We share announcements and we provide links to past virtual event recordings. And next slide, please. And Beacon is essentially getting patient navigation going in lots of places around the world. Currently we have 45 member organizations that are participating in Beacon, and our community continues to grow. Next slide, please. So here we can see a breakdown by region. Our member organizations include both health institutions and cancer organizations from around the world. And I know some of you are already in the room, so hello and thank you for being part of Beacon. Next slide. And here are the member organizations based in the Americas that are currently part of Beacon or have been in the past. Next slide. So while the toolkit is developed in English, it can be translated, at least the online text, into other languages like Spanish or Portuguese. And you can simply do this by clicking the translation option in the Google settings, or it'll automatically appear for you. Next slide. So we continue to welcome health institutions, cancer organizations, and individuals to join Beacon. It's free to join through an approved application process. And you can learn more about Beacon through the link here in the middle of the page, which is our public page. And feel free to send that to any colleagues of yours. And if you have any questions or you would like to join the community, please reach out to us at acs.beacon@cancer.org. Next slide. So now, in addition to Beacon, I'd just like to briefly mention we have the Global Alliance for Cancer Patient Navigation, and this was launched this year to bring stakeholders in diverse global settings to frame and assess all the challenges in global patient navigation that no single organization can solve alone. So it does have 3 objectives, being convene stakeholders, creating that unified patient navigation framework, mainly around global definitions of patient navigation, common guiding principles, and then that's those successful implementation strategies. And finally, to expand that reach, quality, and sustainability of patient navigation through awareness and dissemination efforts. Next slide, please. So we currently have 9 organizational members from 6 countries in Latin America and the Caribbean that are part of the Alliance. And again, some of you might be here at the conference today, so hello to you. We invite organizations working in cancer care, health systems, research, and policy to join the Global Alliance for Cancer Patient Navigation. It's at no cost to join, so if you are interested, please reach out to us at acsglobal@cancer.org. Next slide, please. And finally, I'd like to mention a suite of resources that can be used by navigators during their interactions with patients. So the Equipped Initiative enables health institutions and cancer organizations in low and middle income countries to train and equip staff to provide quality cancer education to newly diagnosed patients and their caregivers. So the Equipped initiative, it's an extension of what ACS's reach as a provider of accurate cancer information. It also includes the distribution of global cancer education materials for patients and navigations, and these are available in 6 languages. And then in addition, there's a training curricula in English for health educators that can be delivered in person and online. So these resources, they offer this people-centered and accurate and easy to follow cancer information, as well as communication skill building activities in the training resources that navigators can then apply during their interactions with patients. Next slide, please. So here we see the different resources that are offered through Equipped. First, on the left, we have the country-specific and global suites of ACS copyrighted cancer education materials. So these are in the form of a booklet for patients and caregivers, and then a flip chart for health workers. And these are currently in English, Spanish, Portuguese, French, Arabic, and Indonesian. We also have training resources to upskill health workers to use the booklet and flip chart while engaging with cancer patients. So these come in a form of an in-person instructor-led curriculum through PowerPoint presentation and an online self-paced learning. So these resources are also free and they're available to member organizations through an approval process for those organizations to access and use them within their respective entities. Next slide, please. So the text and images in the slide are from the booklet and the flip chart. So this shows how we use easy to understand language, as well as imagery, and to get that closer to meeting the needs of the populations that our partners or organizations are serving. So it's good for patients who might have less formal education, less resources, or they may be impacted by myths and stigma to seeking appropriate and timely care. Next slide, please. So up until now, we've been offering Equipped to our partners in Kenya, Uganda, Ethiopia, and Indonesia, and Brazil. But on December 11th, we'll be launching Equipped to the global community. So please do feel free to join the launch event to find out more about, what is this initiative, how it might benefit cancer patient education, how the initiative might support your patient education activities, and how you can get access to the resources. So we welcome any cancer organizations, health institutions, particularly from LMICs or other resource limited settings to join. So you can join, please send us an email at acs.equipped@cancer.org if you're interested in joining the launch. Next slide. So finally, I believe there's a fair or virtual mural that's available later today. So we will have some resources available there on Beacon, the Global Alliance, and Equipped if you'd like to learn more. So please do visit those. And then lastly, I'd just like to thank MPI and the Pontificia Universidad Javeriana for allowing us all to participate. And thank you to everyone for your time. And I look forward to the discussion.
Muchas gracias, licenciada Jenna. Le invitamos para que después
Thanks
de la
so much,
conferencia
Jenna. We invite you to be present in Dr. Mandi's panel. We welcome Dr. Mandi Pratt-Chapman. Please, doctor.
para poderle... Buenos días.
Okay, good morning.
That's about all I know in Spanish. So I apologize. I'm so pleased to be here today. I'm Dr. Mandi Pratt-Chapman from the George Washington University Cancer Center. I've worked a long time with MPI and with Nancy And I'm going to share with you some research results from a study that I did a few years ago that where we were investigating how do you make successful patient navigation programs. So we heard from Dr. Freeman why we need patient navigation, and we heard from Jenna lots of resources on tools for implementing. And what I wanted to do in this study a few years ago was to talk to people who were in programs and find out what were the key ingredients that they needed to have a successful program. So our research question again was, what are the implementation factors that are important for a successful and sustainable patient navigation program? We interviewed 17 stakeholders from across the US, and these included navigators, their supervisors, and administrators. And we asked them a series of questions that were guided from what is called the EPIS framework, I don't have that memorized, Exploration, Preparation, Implementation, Sustainability. So we used that as a framework in order to guide our semi-structured interviews. And this is a breakdown of the participants in our interviews. You can see that there's a mix of individuals from across the US, mostly female, from broad regions in the US, well-distributed in terms of rural and urban, and mostly patient navigators, but also a fair number of administrators and supervisors. And this again is the EPIS framework that I mentioned. So we wanted to look at inner context factors, outer context factors, bridging factors that might facilitate patient navigation, as well as individual program innovation. So one of the first high-level themes that we found through our research was the demonstrated need for services. And this came in a number of different ways. Most of the rest of my slides are going to be a little wordy because they're quotations. So in this program, they said, based on previous research looking at minority, underserved, English as second language, because those are the people who benefit most from navigation, we've seen a decrease in time to diagnosis. We're looking at screening adherence, and then again at time to diagnosis or whether definitive resolution if it's not cancer. And I just want to point out here, Dr. Freeman also authored an article about principles of patient navigation, and this quotation really highlights a number of ways that you can put boundaries around your navigation program. So first, the population being served was identified. So this program identified who would benefit the most from these services. Second, they chose a time point. So they looked at screening adherence and time to treatment. So they really wanted to reduce the time, and that was their metric, was reducing time and maintaining adherence. So that's one way to show value, is to show through a change in, say, time or access. This other program showed value and demonstrated need for services by showing how there was a need for patient navigators to do financial navigation. And so rather than the patient receiving a large bill at the end of their cancer care treatment, the navigation program was really designed to help the patients understand what costs were coming up so they didn't have a big shock, and it wasn't devastating at the end of their care or throughout their care. Another way that a program showed demonstrated need for services, they had patients with a lot of late-stage disease, and this is also something that was true in Harlem when Dr. Freeman implemented his program. And so the goal of this program was to really downstage disease and reduce the number of late-stage diagnoses in their institution, and make sure that people were getting their cancer screening. So whereas one program was looking at screening adherence and time to diagnosis, this one was really trying to downstage the cancer for greater survival. So the second major theme that we identified in our study was external incentives, and these also looked like a variety of kinds of things. In this program participated in the oncology care model, and the oncology care model was a value-based model in the US that required patient navigation as a component of quality care. And so this program was able to reinforce their program and get additional resources for their program because of this external pressure of the payer. And the payer was saying, you need to have navigation services. By demonstrating those services, they were able to get paid, and then through that, they were able to reinvest in their program. Another external kind of factor or incentive is accreditation. So this other program mentioned that they were participating in the American College of Surgeons, cancer accreditation, and this is a very widely known and reputed accreditation in the United States for quality. And this program also requires patient navigation. It's varied a little bit over the years from a patient navigator to a patient navigation process, but the need for accreditation and maintained accreditation was a strong external incentive for the program to be successful and demonstrate why they were so critical to their institution. Another thing that's very common in really any kind of program implementation is leadership support. So internal leadership support for this program at the highest level enabled this program to be successful since people were paying attention at the very high levels in terms of program implementation and success. Another key factor to success is role delineation and scope of practice. So navigators are coming in with community knowledge. There's a rich history of community health work, of nursing, of social work, and really identifying what is the role of the patient navigator and how do they complement and work with the team is critical. So at this institution, they mentioned that they go through and they find out, what is the best process for the navigator, how do they ensure team fit to optimize the success of the program. Right along with that is clear protocols for organizational context. So it looked like there were lots of great materials in the toolkit that Jenna mentioned, but having an idea of what you really want to accomplish and how that's going to work within your institution. In this case, they were very focused on emergency room visits and trying to prevent hospital admissions or additional emergency room repeats. And so what they did was if someone came into the emergency room, they would follow up and say, did you get what you need? How are your symptoms? And try to make sure that the patient was, the symptoms were managed and the patient knew what to do so that they could avoid another ER or emergency room visit. Another key theme, training support. So this is why NPI is so important. So making sure that you have training on the fundamentals of patient navigation, which I will talk about a little bit later today, but also the specifics of your particular context and what you need to do in practice as a navigator. And then I think a number of things that I've mentioned already speak to this, but just kind of very clearly the ability to demonstrate value is also a theme in our data in terms of navigation program success and sustainability. So in this example, showing positive impact to leadership was key to demonstrating value and showing the impact on patients. At this institution, they looked at patients who were navigated versus those who were not navigated and what those outcome differences were to demonstrate value. They also identified that by retaining patients in the system, that this was actually the most profitable program that they had ever evaluated. So that was a huge demonstration of value for sustainability of the program. And then funding stability is also closely related to that. So this navigator mentioned, if someone says, oh, this is really important, but then when the free money goes away, the program doesn't have support, that is an indicator that the program is likely not to be sustainable. So finding those internal champions, those clinician champions, physician champions, administrator champions, and how you're going to demonstrate success and establish that funding stability is really key. So this just shows you kind of where the themes that I talked about fall along the EPIS framework that I mentioned. And so there's in Spanish, and then for those of you who want English. And I also wanted to share with you this framework from the World Health Organization. I was part of the development of a technical paper through the World Health Organization where we looked at patient navigation, scalability in low middle income countries. And this was the stepwise process that they provided in terms of implementing a program, which included knowing, engaging your stakeholders, again, finding those leaders, identifying your priority patients, identifying the scope of your program, implementing, piloting, and evaluating, and then continuing to refine. So I think this is a helpful and easy process to follow that I think aligns pretty well with what Jenna was talking about, as well as the materials that I can speak to later today. So overall, these are just the key takeaways. If you fell asleep while I was talking, this is your quick catch-up. So what I would like you to remember and take away are get clear on your funding and your financial investment, like how are you going to support your program? How is your program going to be sustainable, and what supports the resources for your program? Identify your need. So what is it that your patients are experiencing? Where are the gaps? And where's the greatest need, whether it's a particular patient population or a particular part of the cancer continuum, or a particular aspect of the cancer care process. Identify where's the problem and how are you trying to fix it? What is the role of the navigator in that process? And then again, I mentioned this several times, but engaging key stakeholders, so finding your leaders, finding people that are going to champion your work internally. And I think, a really important piece that I hope that this helps inform is, while the navigator is a bridge for the patient to the institution, the navigator can't operate alone within the institution. So they really need these leaders and champions to help connect them within the institution so that they can facilitate that assistance to the patient. So this is really where you find your stakeholders. And then you also need external folks at community-based organizations where your resources are coming that you are going to navigate your patients to. As I mentioned previously, identifying kind of clear role delineation, scope of practice is really important so that people can operate optimally as a team. And then clear protocols that fit the organizational context that account for the capacity you have as an organization and the resources available. And you've heard this several times now, but training is important at various levels in terms of understanding the process of the cancer continuum, the process of your particular institution, and what the patient in particular is going through in that journey. And then finally, always, I always love getting feedback because I try to make things better. I always think 6 months ago, how did I not do this differently? So like making sure that you're evaluating your program, looking at your data, where can you improve and refine so that you can continue to have a really strong impact. And these are just the references that I mentioned throughout my presentation and my contact information. So thank you so much.
Muchas gracias, doctora Mandi.
Thank you so much, Dr. Mandi. So we welcome and we open up for this conversation, Dr. Jenna. So we ask the audience to prepare the questions for the people who are online via Zoom. You can write the questions into chat and we will pass them on to our guests.
Thank you so much. I don't know if, all right.
Okay, ahora
Jenna,
sí.
can you hear me?
¿Ya me pueden escuchar? Jenna, sí, un poco bajito. Ahora sí, mejor. Ok, muy bien.
Better, yeah. I was like, it's a little faint.
Sí, mejor. Ok, muchas gracias. Muchas gracias por tu presentación reciente. Estamos esperando para ver si hay preguntas en la audiencia y recolectar preguntas también de los participantes en línea. Entonces, no estoy segura si hay alguien acá en la sala con preguntas en la audiencia. Por aquí.
Si puede levantar la mano si tiene preguntas ahí.
Ok, hay alguien. Sí.
It looks like somebody does have one. Thank you so much, Dr. Pratt-Chapman, for your presentation. That was excellent.
Good morning. Excuse me, but a little is English. I prefer in a question in Spanish, is possible, or in
No,
English?
sí, pregunte nomás en español, señor, por favor. Sí.
Ay,
Por
muchas
eso tenemos
gracias.
los intérpretes,
He's
no se
going to use
preocupe.
Spanish. He's going to ask the question in Spanish. He prefers. Okay. Congratulations and welcome, Dr. Mandi, Dr. Peña, Dr. Jenna. Thank you very much for sharing this knowledge, very interesting experience for a treatment on cancer and other chronic diseases. A short question. Considering the progress made by President Biden in the former administration, yeah. So what impact has the One Beautiful Big Bill promoted by Trump has had in terms of the Medicare and Medicaid and for the migrants in the United States to access to cancer treatment or treatment for other chronic diseases? That act, Big Beautiful Bill, what impact has it had, and what's going to be the impact for the access of healthcare for the migrants in the United States is my question.
So I think that would be a good question for Jen, if it's okay for Dr. Pratt-Chapman. Is that all right for Mandi to answer?
Yeah, I think that's more appropriate for Dr. Mandi.
Okay.
Yeah.
All right, thank you for the question. It's devastating, honestly. I mean, I think our nation is highly divided, and our research enterprise and our political system is not in sync right now. So the incredible leadership of Dr. Freeman and the incredible research that has laid the foundation for this innovation is definitely not aligned with what current administration and the limitations are doing to healthcare. I'll name just three major concerns. You mentioned migrants, so I think at every level there's concern about safety at a basic level right now. And I know we had a breast screening campaign. We have a lovely community partner that's been long in the community named Nueva Vida, and we scheduled 3 free mammogram events. And I'll call out my wonderful colleague, Claudia Campos, who was key to that and hopefully listening. And we had a number of women who didn't want to come and didn't come because they were afraid of being facing ICE. So we did eventually get folks to come back and get their screening, and we successfully navigated everyone who had adverse findings, and at the end, nobody had a positive diagnosis of cancer, but it's a serious concern. So that is one major implication. I would say the second is, you also mentioned Medicaid. So if the Medicaid cuts of the bill that you mentioned do actually come to fruition, I have a very small sliver of hope that maybe if we vote different congressional leaders in 2026, maybe that will be prevented, since it was scheduled to really phase in 2026 after the elections, I think also for political reasons. And so if that does come into effect, a massive number of people will have loss of health coverage, and that will mean it's much harder for the navigator to do their job and much harder for patients. And the third area that I'll just mention is that we do have a major financial problem with sustaining our comprehensive care through the Affordable Care Act. And this massive change that the current administration has issued in also will affect rural areas even more than urban areas. So we are facing some pretty big cliffs, and I appreciate your astute insights into that challenge, and I hope that we'll be able to address that the best that we can. So that's what I got.
Thank you so much. Thank you so much, Mandi. It's incredibly challenging, and I think knowing that patient navigators, one of, I feel like, the superpowers is to adapt and to find solutions, but also realizing that, the hope always is that the climate around, and then in terms of the political climate and policy, exactly, continues to support that. Very challenging when that's not what we're seeing. Yeah, thank you. I was wondering if there are other questions, otras preguntas acá de la audiencia acá o en persona o por Zoom.
Tenemos tres preguntas.
Yes, we have three questions online from Valeria Bernal. She's online right now. What are the main challenges in this area? In this area of patient navigation, yes.
Okay.
The three main challenges, or the main challenges. Yeah.
Yeah, I did. I mean, there's so many barriers that we can discuss, and I think it's kind of difficult to hone down on them because the crux of patient navigation is really to address any barriers, whether it's access, communication, so being able to understand the cancer education that your new diagnosis, let's say, to cancer. It's also, your finances, as Dr. Mandi was saying, financial instability is really difficult for a patient. It's one of those key barriers and something that every country is kind of tackling in their own way when we have, maybe a national health insurance, but that doesn't cover cancer, comprehensive cancer treatment, or if we've got a private situation for healthcare that, again, isn't meeting those needs. So the key ones, I would say, is probably financial barriers in a way. I would say also being able to communicate really what treatment process a cancer patient needs, and then also being able to adapt those communications, being able to provide what the cancer patient needs, through that continuum of care. But like I said, there are so many barriers. I would never want to just focus on, some of those key ones. I mean, I would want to tackle as many as possible. But I'll hand it over to Dr. Mandi to chime in.
Sure. I'll just give you a current study that I'm leading with my colleague, Dr. Hannah Aram in Washington, D.C. We have systematized screening for social needs across 5 cancer centers, and we're providing navigation services kind of on the latter end of treatment after folks have received at least one modality of treatment. And I will tell you that in Washington, D.C., across these 5 hospitals, the 4 greatest barriers on the patient side that we've seen are paying for the basics, so financials, as Jenna mentioned, and all of these are related really to that, food insecurity, transportation, and housing. And unfortunately, because of some of the changes that have materialized this year, we have fewer resources in our community to address those barriers. So I guess I just wanted to jump on to say, the patient navigator isn't a magician, right? We really need, as Dr. Freeman mentioned, advocacy for policies that are supportive. And while in the US, some of our policies may not be going in a supportive direction, clearly the navigator can be more effective when there are community resources and policies that are able to facilitate addressing those patient needs. I'll also just say from an institutional perspective, historically, I think we've had some tension between navigators and other roles, which I think is why role delineation is so helpful in building that team and process. I think that's better than it used to be, by just being clear about who is doing what. And then funding sustainability. So while we do have the Medicare reimbursement, it's been difficult to implement so far. It's always hard to implement something in a complex system. So really figuring out those workflows and figuring out a rate that is appropriate for the navigation activities where we can really sustain the services. So just at the patient and institutional level, those are some things that we've encountered.
Tenemos otras preguntas del público, de las personas
We
que están
have
conectadas.
some other questions from people online. I will read or summarize 3. That will be the last 3 for the sake of time. This question is for Dr. Mandi, and it says, in the highly fragmented network and diverse territories like ours, for example, in the south of Chile, what indicators would you suggest to use to indicate whether navigation is being successfully implemented and the teams are achieving the expected outcomes in highly fragmented networks?
Yeah, that's a great question. It's hard because I don't know your geopolitical context that well. But I think what Dr. Freeman mentioned in terms of really understanding what is your patient need and what does the data look like. So I don't know if you have comprehensive screening and comprehensive data available to diagnose whether people are getting screened. Having a quality registration program where you can see where the disparities exist, whether that's getting to screening or getting to treatment or getting through treatment, I would say let the data guide you. Where do you see the most loss in terms of life and quality of life, and build your program around the biggest need, and then continue to grow from there.
I was actually just curious too, Jenna, if there's something that maybe you could offer in terms of thinking about what Beacon provides and what your programs provide that might be helpful for the participant who actually, the attendee who
Yeah, so I was mentioning the toolkit and how we have these 3 phases. So in that beginning phase, I think you made reference to this, Dr. Mandi and Dr. Harold as well, is that that need assessment is really important. So, in the toolkit itself, we provide sort of guidance and resources on how you can do that needs assessment. The good thing is like, because there's so many of you from all different countries and different walks of life, these resources then can be adapted to what you need to do in your cancer care setting. So just like Dr. Mandi was saying, it's like, it's always hard to understand what you need to do to get to that evaluation stage. But the good thing about Beacon is that you can kind of tailor those resources to your setting. So I would start there. And then in terms of like other resources that would be available for you to kind of monitor and evaluate, then that takes you into that phase 3 of the toolkit, and also provides, some various things that you can do either through routine monitoring or, doing more of an extensive like evaluation for your program.
Thank you both so much. I think we have, was it one more? ¿Una pregunta más?
Hay dos muy importantes.
Hay dos importantes,
Vamos a tomarnos
Yeah,
este tiempo
there's a couple of important questions. We will ask them because that's the idea of this Congress, to interact. There is a question from Claudia Campos from the George Washington Cancer Center for Dr. Mandi.
Why is important to consider from the beginning how we will evaluate a navigation program, how we will ensure data accuracy that you said right now, and how we will disseminate the results or present the results.
Yeah.
Kind of thing.
Yeah. So la doctora estaba preguntando si tiene sentido como con las dos preguntas y hacer las dos a la vez para ahorrar tiempo.
Sí, yo creo que sí.
So maybe if you can ask both questions. The other question is not very connected, it's quite different. So, okay.
Thanks, Claudia. So I'm not sure what to add beyond what I mentioned previously, but we have some pretty rigorous data checking in our evaluation process to make sure that we're capturing the value of patient navigation. And then in terms of disseminating our results, we do publish in the literature for academics, but we also disseminate our findings through educational products. And I think you can also use policy briefs and social media, trying to reach people at various levels. So to try to be succinct, I'll leave it there.
Thank you. Jenna, is that something you could respond to as well? Were you able to hear the question?
I didn't hear it quite well, but is it about dissemination? So, disseminating your evaluation findings, is that correct?
Dissemination of results, yeah.
Yeah, so I would say, I agree with Dr. Mandi said, but also, I think what we're currently grappling with SPARC and the Global Alliance is like, what are those kind of forums that, yes, reach people globally, but then also thinking about your kind of grassroots change. And I think Dr. Harold made reference to that as well, as like, or maybe that was a question by Nancy in terms of like policy changes and so forth. So I would look for the target. What is it that needs to change and what is it that needs to make a more enabling environment for those, needs that are really, that you're trying to grapple with what questions you were trying to address during your evaluation. And I think that would help navigate where you want to disseminate your channels. Is it at the government level? Is it more of a global scene? So, do that inventory before you start your dissemination.
Thank you so much.
Yeah.
Esa es una pregunta un poquito retadora.
This is a little bit challenging question. Have you eventually considered increasing the area of intervention of navigators outside of the oncology area, such as in other medical specialties, with chronic pathologies such as rheumatology, diabetes, due to this high prevalence around the world? Because they require specialty treatment also due to the comorbidities. Would you think about developing some support tool as it was developed for oncology?
Yeah, there's actually been quite a bit of work in other areas. I just don't know a lot about it since I'm in the cancer space, but there certainly has been a lot of navigation in chronic disease areas. I was part of a study tailoring navigation for PrEP for cisgender women in the DC area for prevention of HIV. So there's a decent amount of navigation in the HIV space now. Definitely kidney area. I think that you're right in pointing out the important thing the question is pointing out is that the skills of the navigator broadly are very transferable to helping the patient through other processes, but an understanding of what that particular disease site and those pathways look like is really important to be effective.
Thank you so much. Jenna, is that something you could also respond to?
I would say, I don't think I have a proper response for that. I feel like Dr. Mandi's, in terms of her implementation, she'd be the better person to respond to it. Yeah.
Absolutely. Thank you. Thank you so much. Thank you both so much. I think these were amazing presentations and just really appreciate the questions that the audience had as well. And I think we'll wrap up because I know we're a little bit over time, but thank you. Appreciate it.
And just to let the people know online, I'll respond to any questions through the chat as well.
Oh, absolutely. Thank you so much.
Yeah, of course.
Thank you.
Thank you.
Muchas gracias. Los invitamos a la estación de café y les pedimos.
Thank you so much. So now we invite you for a short coffee break. Please be back at 10:10 to continue with our presentation. Outside the room, there's coffee.
Mi nombre es Alexandra Núñez, soy presidenta de Unidos contra el Cáncer, una organización de pacientes que desarrolla el programa de navegación en el Hospital México en San José, Costa Rica. Para mí y para la organización que represento, esta certificación de NPI tiene un gran valor enorme, ¿verdad? Porque nos permite profesionalizar el acompañamiento que venimos dando a los pacientes, pero ahora de una manera más sistematizada, estructurada y con un respaldo de todo el aprendizaje académico que tuvimos en estos meses, ¿verdad? Aprendimos que la navegación no es improvisada. Necesitamos conocimientos, herramientas, indicadores y estrategias que nos permitan guiar mejor a cada paciente en su recorrido dentro del sistema de salud que ya de por sí es complejo. Esto especialmente porque imagínense en medio de la incertidumbre que significa un diagnóstico de cáncer, contar con alguien capacitado que nos acompañe, que nos oriente, que nos ayude a pasar esas barreras, marca una gran diferencia en la experiencia del paciente y su familia, y lo digo como paciente que fui y que hubiera deseado contar con este tipo de apoyo. En el caso de nuestro programa de navegación en el Hospital México, esta certificación viene a fortalecer lo que hemos estado haciendo, asegurando que cada persona no se pierda en el camino, que tenga acceso oportuno y que se sienta acompañado. Quiero resaltar que en las clases aprendimos la importancia de contar con el apoyo de los equipos multidisciplinarios, y como navegadores nuestro trabajo debe ser vinculante con el hospital. No es un esfuerzo aislado, sino un acompañamiento estructurado que ayude a reducir esas barreras de acceso, esos tiempos de espera, y que los pacientes reciban una atención oportuna y humana, ¿verdad? Bueno, yo hoy celebro que ya no solo tenemos la voluntad, sino también la formación profesional que nos respalda y nos compromete a seguir creciendo para dar lo mejor a los pacientes. Y quiero aprovechar para agradecer a nuestros profesores, en especial a Nancy, que con tanta entrega lideró todo este proceso de aprendizaje, a mis compañeros, porque juntos hicimos esta certificación, una experiencia de aprendizaje compartido muy valioso. Me encantaba cuando compartíamos las experiencias, y como dice el lema en Unidos contra el Cáncer, juntos transformamos el dolor en esperanza. Muchísimas gracias.
Mi nombre es Hernández, yo soy la presidenta y soy fundadora de la Asociación Metamorfosis, pacientes hemato-oncológicos acá de Costa Rica. Actualmente soy estudiante de la carrera de Psicología de la Universidad Católica de Costa Rica. La capacitación de navegación internacional me ha parecido muy enriquecedora por ese sentir humano que tenemos tan cercano hacia el paciente. Me deja un gran aprendizaje porque a pesar de que nosotros ya somos y hemos sido voluntarios por muchos años, nos viene a brindar herramientas prácticas y en un marco